Did you know that one of the most common risks of an epidural is that in 1 in 10 cases, it will not work effectively? And I'm not doing this video to scare any pregnant mum to be, but so that you are aware of the risks going into labour and birth and having an epidural. I myself had a perfectly working epidural. I was very lucky, it worked brilliantly. But as a midwife over the years, I have seen epidurals work fantastically well and stop working suddenly in labour. I've also seen them not work from the outset, and I've also seen the conversion of epidurals to general anaesthetics during emergency birth procedures such as a caesarean birth or during a forceps. Leave your experiences of having an epidural in the comments below. When an epidural doesn't work though, your midwife can do certain things that might help it become more effective, may help it work, or potentially refer you back to the anaesthetist who can potentially come and resite it, so reinsert that epidural. One of the most common reasons an epidural doesn't work really effectively is sometimes that epidural catheter that goes into the epidural space is slightly tilted to one side. So your midwife will be checking your block with ice cubes or something cold every hour that you are in labour, and they will be testing just how high the dermatome levels are. If they notice that your dermatome on one side is much lower than the other, they will turn you onto your side. So epidurals and the dosage of epidurals work with gravity, and so sometimes just by turning you onto your side, it will help that epidural drug actually make the side that isn't quite high enough much better. Another aspect where women will feel pain during their labour and birth with an epidural is having a full bladder. Your midwife will be recommending that you have a catheter placed or that you have intermittent catheterisation, so that's where they place a tube in and out every time that an examination happens. Because if you have a full bladder, that can cause breakthrough pain abdominally, which stops the epidural from working effectively. And if an epidural is not working at all, an anaesthetist can come back and resite it and put. However, it's being aware that during an emergency procedure, this is not always possible, and conversion to a general anaesthetic sometimes happens. In terms of who is more at risk of having a failed epidural, there are many studies on this area. Having a more junior anaesthetist site the epidural increases the chance of epidural failure. It is worth noting that even the most senior consultants and anaesthetists do have epidural failures though. Having had babies before, having a history of previous failed epidural analgesia, having a cervical dilatation of more than 7 centimetres, because it's that pressure that women often feel at that stage, and they're designed to remove the pain of contractions and labour and childbirth, but they don't necessarily remove the pressure. Having a high BMI, having a prolonged labour, having lots of different top-ups during labour and birth also increase the chance of epidural failure. And here you can see the epidural and combined spinal epidural failure rate. So it's about 1 in 10. It's one of the most common risks with having an epidural in labour and birth.